regarding the time of the surgery, what should be the time gap between the injury and the surgery? What should be the time gap for isolated ACL?
Ashwin, I think you spoke a bit about it. You were the drug
I'm in no rush to operate. I really want, it's not necessarily the timing. I definitely don't do an ACL reconstruction before the first 3 weeks. I want the knee to be nice and quiet, got good range of motion, like a physiology can load their knee. Okay, so a lot of rehab. So I call it aggressive physio programs for physios. The key thing there is handling the patient's or the individual's mind. Because particularly the competitive athlete, they want to get back to sport as quick as possible. Why don't you do the operation today, don't do tomorrow? Particularly now, I've seen a few skiing incidents that have come back from Austria. So, and they literally before I came, she wanted surgery immediately. And it takes another extra 5-10 minutes explaining to them why we should not operate immediately, why we need to get the knee nice and soft and supple. Because in a stiff knee, post-operatively, you only get one thing: increased stiffness. So you want to avoid the risk of arthrogryposis.
Is there chance of infection also increases in early surgery?
I don't think that would be the case, no, unless it's an open injury or abrasion. But obviously, if there's a large hematoma, you could theoretically describe. I don't think infection would be a thing. The main thing really is arthrofibrosis.
This is provided there's no bucket handle there, the knee is not locked, the usual.
It was there, it should be.
Claudia, I think.
Graph diameter 9. But mostly in India, we are dealing with the ACLs which are mostly non-athlete, for example, rotator accident or something. That's why once we take semi or hamstring, the diameter is mostly 7.5 or 8. So after that, we are shifted towards the peroneus. Are you doing the peroneus harvest in case of primary ACL?
Okay, we can ask the panel this question. I think there was a nice case presentation in the morning. Okay, for me, no peroneus. I don't want to bugger up the ankle to fix the knee. Rich?
Yeah, I don't do peroneus anymore.
Similarly, I don't want to cause a problem. That's a problem.
Actually, for primary ACL, I hamstring tendon grown in my first practice. But the second case with the revision case, I use a lot of PLT. It's easier, half is long enough, and our study show more than 5 year ankle problem, no problem. So PLT is my second choice. If a hamstring tendon is weak or be healthy before, it's a good option for graft or use a PLT tendon. Thank you.
And sir, regarding the female patient, diameter 9 causes, there is it touches the condyle of the femur. How often, ma'am, you go for a notchplasty during that?
Yeah, normally, almost always, because I use that ruler just to make the measurement of the intercondylar notch. And normally, if it's less than 13, I always make a notchplasty. So I try to have a good graft. Normally, it's related. The literature that if you have a good big graft with a smaller notch, probably you will have a high rate of failure. So I always make a notchplasty there.
Okay, we'll give good one kid. We'll good one kid now.
Sir, I have a question for you.